I get started? Oh, the microphone is on. Some of you do care, and it's a very common cancer. As Dr. Tabayoyong will share with you, over 83,000 new cases of bladder cancer are diagnosed annually. And about half of all cancers, when we find them, they are still contained in the bladder wall, but a good number of them, we find them when they are deep into the bladder, where we have to actually do bladder removal surgeries, which Dr. Tabayoyong is an expert in. The rate of bladder cancer, as far as the rate of cancer deaths, fortunately, have been dropping in recent years thanks to the great work that Dr. Tabayoyong and others are doing, which he continues to do. For many reasons, this talk is important for you to be part of. It's a very costly cancer, costing us over $2.5 billion annually. And there are many risk factors to this disease. And our goal is, of course, this evening is really education. We want to share with you what we've been doing and the great work that's being performed at our medical center and how to really improve the outcome from this disease. And of course, the treatment, the prevention techniques, and of course, the research that we pursue. Such a common and such a significant public health problem, important for us to tackle it from multiple directions. So you're going to hear again from one of the world's experts this evening, whose career is dedicated to bladder cancer care and research. So without further ado, Bill, again, thanks for your patience as we sort out the logistics of the electronic format. And those of you online and those of you who are in person, as I said earlier, you're in for a treat learning from my colleague, whom I appreciate greatly, Dr. Tabayoyong. John, thank you for the introduction. You're right. I would not have been able to say all that about myself. I appreciate you saying that. So thank you for everyone who is here in person. I count 30 plus people in the room. That's very impressive, and I'm very happy to see all of you here. I think there's another 40 or so people online. So those are your faces that I cannot see. Know that I'm happy that you're also here along for the ride with us today. Now, one quick question. I like to move, especially in this hybrid setting. I know that there are people at home and there's people in the audience. I like to move around. If I move, how far can I move from the microphone before we start? This is it. I can't move. You tell me I have to stay right here? Okay. Okay. So the guy says I can't move, so I have to be animated here. But again, thank you all for coming. I'm very happy that you guys are all here. Just a quick show of hands. I know I recognize some of you because some of you are actually patients of mine. And so thank you for coming for support. But how many of you here have bladder cancer? Just out of curiosity. Many of you. And how many of you here are supporting someone that you love that has bladder cancer? The other half of the room. And how many of you have never heard of bladder cancer? No one, maybe one people present. And how many of you here like me that just want cookies at the back of the room? Everybody. Okay. So May is Bladder Cancer Awareness Month. Okay. And so a lot of you here have bladder cancer or taking care of a loved or helping take care of a loved one that does have bladder cancer has afflicted them. And really, bladder cancer, there is quite
a breadth of what it can do for people, how it affects them, their lives, and the challenges that it proposes for people. But again, I'm glad that you guys are all here to talk about bladder cancer. This is something I talk about all the time. As Dr. Joseph mentioned, this is what my career is mostly dedicated to, is bladder cancer. And again, Bladder Cancer Awareness Month, just some of this stuff here. Yeah, so this, as Dr. Joseph mentioned, I joined faculty a few years ago. I've never given one of these patient education seminars. And one of the things that I was trying to figure out how to do this today is what would I want to talk about as far as bladder cancer goes. And the way, as a patient education seminar, the way I approached it was, I'm going to tell you exactly everything that I tell my patients in the office, so that you guys have all the information that I have. Because I don't want you walking out of my office not understanding what your disease is, where your care is, and what to be expected, right? And I will take as much time today as you guys need. I know we'll say it until 6:30. I know people in the room got other places to be, but I do this all the time. If we go long, and I'm here, okay? And the other thing, just as a quick aside for Bladder Cancer Awareness Month, I know some of you who are my patients, you always want to know what socks I'm wearing, because I always wear the socks. So they're bladder socks, just so you're aware, for bladder cancer awareness. They're not just white athletic socks, they got nice bladders on them. Okay, so that being said, and this lecture or this talk, as I mentioned, I want it to be something for you all to understand, so you walk out of here understanding bladder cancer. The information here, a lot of it is what I tell my patients, but this is the exact same lecture I give to second-year medical students, right? So, because most medical students aren't going to become urologists, but I want them to understand what bladder cancer is and when to send it to me appropriately. And a lot of the information that I give them is what I'm going to give you today. And there's some new wrinkles here because we just got back from our annual meeting. The American Urologic Association annual meeting in San Antonio was the beginning of this month. And there were some new studies on some new drugs in the bladder cancer space that were introduced that are approved by the FDA, and I'll go over them here today, just so that we're all on the same page. But just to get started, what do I want you to learn today? If we can walk out of here learning something more. So what are the signs and symptoms of bladder cancer? Important to know. Obviously, blood in the urine is the biggest sign, which we'll talk about. But understanding hematuria or blood in the urine, what the workup is involved. Bladder cancer staging. For those of you I take care of, I always tell you, I want you to know what your final pathology is on your bladder biopsies. How aggressive is the disease? How invasive is the disease? How does that affect managing? Is it non-muscle invasive? What are your treatment options? Is it muscle invasive? What are your treatment options? And then I don't particularly take care of patients with metastatic bladder cancer because that's outside of the realm of urology. But you know, I do work very closely with medical oncologists to take care of patients with metastatic bladder cancer. And there are some interesting or some newer drug developments that have happened in this space that I will talk about today also. Just for other housekeeping things, this is not meant to be me speaking at you. I'm happy to take questions as they come up. Anyone here in the audience that has a question, raise their hand. I'm happy to stop as we go. Those of you at home, put your question in the chat box, and depending on how the flow of the talk goes, we'll either save them for the end, or if there's a pause or a break and it's a question that is pertinent to the discussion we're having ongoing with people live in the room, we can bring the question up as it comes across. But we'll see how that goes. But again, I don't like to hear myself just talk for an hour on. So if you guys have questions, please feel free to stop me, and I'm happy to slow down and talk about other things or any questions that you have. So these are the learning points. Hopefully you'll walk out of here understanding a lot of these things. And so just to start, as Dr. Joseph mentioned earlier in the introduction, how many people are affected by bladder cancer, how its rates are on the rise. But you know, this is the, oops, you got me on the oops. This is the 4th most common cancer in men, 5th most common malignancy overall. Interestingly, it affects men more than women. 4-to-1 male to female ratio. But when women get it, they tend to have it more aggressively than men do. There's something with estrogen and testosterone that plays a role in bladder cancer development and how aggressive it is. We don't know the answer to that yet. That's part of of an ongoing research, but we don't know the answer to that yet. But we do know men are more affected than women, and women tend to get more aggressive disease than men. Now, risk factors, tobacco smoke. Smoking is the #1 risk factor for getting bladder cancer. Carcinogens in smoke get in the lungs, into the bloodstream, and then they filter out and sit in the urine and bathe the urine. And those carcinogens, when they bathe the surface of the bladder, can cause mutations, which then cause bladder cancer. Now, interestingly, a lot of people thought that this 4-to-1 male to female ratio of men getting cancer more than women is because more men smoke than women. And actually, that's not true. Because when you look at studies that have looked at men who smoked heavily and women who smoked heavily, and you across the board, that 4-to-1 ratio was still the same, but women were still getting worse disease. Okay. The other thing that is interesting, especially in this era, with Xerox and Kodak and all of the different chemicals that people who work in those factories were exposed to, or even not quite so close to home, but close to here, veterans who were in Camp Lejeune exposed to different types of chemicals. So aromatic hydrocarbons and amines and nitrosamines, metals and inorganic compounds. These are also risk factors for developing bladder cancer in addition to tobacco smoke. Now, the one thing that many of you who have had bladder cancer, treated for bladder cancer, you probably first saw this. This was your first symptom, blood in the urine. Oops, you hit the wrong button, sorry. Blood in the urine, hematuria, most common symptom in patients with bladder cancer. But it's not the only thing that can cause blood in the urine, bladder cancer. So the cancer rates for patients with gross hematuria or visible blood in the urine, depending on what study you read, 13% of patients to 34% of patients who have blood in their urine end up having cancer, bladder cancer. And microhematuria, which is blood seen on a urine analysis, urine dipstick test under the microscope, not visible to the naked eye, 0.5 to 10.5% of those patients have bladder cancer. So not everyone with blood in the urine, either microscopic or gross, has bladder cancer, but that's the #1 hallmark feature that we find, that is the symptom that brings people in the office. Another thing that people can have that have bladder cancer are irritative voiding symptoms. Urinary urgency, burning when they urinate, increased urinary frequency, waking up at night to go to the bathroom. So if you look at these and you look at this, a lot of people can have these symptoms and not have bladder cancer either, right? So a lot of these, urgency this year, urinary tract infection, men with big prostates get up at night a lot to go to the bathroom. So there are multiple things that can cause symptoms that are similar to what people have when they have bladder cancer, but not all of them are tried and true for having bladder cancer, although blood in the urine is the biggest hallmark sign. And so what do we do when patients come with bladder cancer? And when patients come with blood in the urine, and you're sitting down with me in the office and you say, "Doc, I have blood in the urine." Got to figure out what it is. So then 3 things that could cause blood in the urine, other than bladder cancer. The other top 2 things are urinary tract infections or kidney stones. And so we got to rule all 3 of those things out or rule one of them in. And so what we'll do is repeat your urinalysis with microscopic analysis to confirm there's blood in the urine. This will also help us rule out infection. We can run a culture also. Urine cytology, we take your urine, we spin it down and look for cancer cells in the microscope. That's another thing that we do. Outside of this, we will do imaging. Cross-sectional imaging, mostly with CT scan. CT scan and abdomen pelvis. This CT urogram I've sent many of you for. The CT urogram has 3 phases, right? There's the non-contrast phase. You go in the CT scanner, they shoot pictures, they don't give you any IV contrast. After you come out of the scanner, they give you an IV contrast, and they're gonna do arterial phasing or nephrogenic phase imaging, or delayed or expiratory imaging phases. I'll go through this in a second, but the non-contrast phase, we're looking for kidney stones or bladder stones. The arterial or nephrogenic phase, not just bladder cancer, but potentially kidney cancer or cancer in the ureter can also cause blood in the urine. So we're looking for renal masses that could be kidney cancer. And the delayed expiratory phase, This is the point where contrast has been filtered by your kidneys now in the urine. And so it highlights the urinary system, the ureter and the bladder. And again, we're looking for filling defects, which could be tumors in the urinary system. And the final thing that all of you are so excited to come to the office to do is a cystoscopy, where we take a camera and put it through the urethra and in the bladder, visual inspection of the bladder. If you're a patient of mine, you know I like to show you your pictures. You guys all get your reports about your CT scans over my chart, and you always read them and call and ask questions, which is appropriate. I always find that the descriptions on the reports are never as good as the actual images themselves, which is why I always like to show them to you in person. Now these are represented images from a CT scan, the different phases that I talked about, the non-contrast, arterial, nephrogenic, or excretory phase. These are not the same patient, okay? And none of these are you, okay? But this is just to demonstrate what we're looking for, what we can see on these images and what to expect. And so on the CT scan showing you here, this is a coronal view, so your head, or the patient's head is up here, feet are down here. This is the right side and this is the left side. This is the right kidney, this is the left kidney, and this white spot at the bottom of the left kidney is a kidney stone. This is what we're looking for on non-contrast imaging. On the next phase, after they give you contrast, you're in the arterial phase, and at this point, contrast is in the bloodstream, and it goes and it filters through the kidneys, and you can see, comparing this is the right kidney here and the left kidney here, comparing that to this image, these tissues are showing up brighter white because contrast shows up as white on a CT scan. And so the contrast is now filtering through the kidneys, and you can see our normal right kidney here. This left kidney has a normal contour, then all of a sudden there's this big round ball. This is a tumor in the kidney, which is most likely a kidney cancer. We're not here to talk about kidney cancer today. The final one is the excretory phase. So at this point, there's still some contrast in the kidneys, but a lot of the contrast is filtered through the kidney and in the urinary system. And this tube down here, and this tube coming in on the right, these are the ureters. Apologize for my shaking. These are the ureters. And this is the bladder down here. You can see all this white is urine that was made from the kidneys that has contrast in it, but you don't see it filling as a complete circle. There's this dark spot here. This is a filling defect, or what we call a filling defect, which is most likely a tumor or a cancer in the bladder. That's what it looks like on CT scan. So these are the things that we look for when we look at for CT imaging. Stones, kidney masses, or bladder or ureter masses. Right? And those of you who have bladder cancer have seen similar images of this or have been through these scans. So then what do we do after we do this, right? Cystoscopy. We bring it back. This is your friend, the urologist handshake cystoscope. This is a picture of the normal bladder. Looking at the bladder neck, you can see nice, smooth, pale pink, the urothelium or bladder mucosal surface. Some muscle striations in the bladder here, and then blood vessels that are the thin red lines. What we don't want to see, but we see often, at least I see often, are these things. These are papillary tumors. Again, you see the normal surrounding bladder, and then I call it a cluster of grapes, but this is what the majority of bladder tumors look like. And if those of you have been awake and watched the screen when we do your cystoscopies, sometimes we see these. And then this is a trip to the operating room for a transurethral resection of a bladder tumor, which all of you, or not all of you, but many of you have experienced or are familiar with. So here we have a cartoon representation of the procedure. We've got a cystoscope going through the urethra and into the bladder with different tumors in the bladder. And at the end of the resectoscope, or the cystoscope, there is a loop hot cutting tool that we use to remove these tumors. This is a cartoon picture again here, normal bladder, tumor. This is the tool coming out of the cystoscope with the hot loop that is cutting into the bladder wall and removing the tissue. This is what it looks like in a real patient. Normal bladder, bladder tumor. And this is the loop after we have removed the bladder tumor down to the level of the wall. Okay. Questions so far? Everybody's on board? Okay. So for those of you at home, the question is, how can we be sure that when we use this tool and hot element and cut through the tumor in the tissue, that we're not harming the bladder itself? So that's a great question. I think that like any cutting or any incision, whether it be a scrape or abrasion on the skin or something in the bladder, there is harm or injury that occurs to the bladder. The thing that we're trying not to do is to cut, is to cut through the bladder wall and put a hole in the bladder. Now that happens inadvertently sometimes, 10% of the time. But the purpose of this is we're cutting in. You're absolutely right. We're cutting it as far as an injury or cutting the bladder is concerned, that would be considered an injury. But this is a controlled trauma or controlled cutting, controlled injury, right? We're removing cancer, disease, trying to get it completely gone from the bladder, and we will fulgurate and cauterize any cuts or bleeding vessels that are here, so that to promote healing and prevent bleeding. All right, but you're absolutely right, and going forward for the next few slides, and again, for those of you that I take care of, you know, how aggressive is the disease, how invasive is the disease. You can kind of tell here that the surgeon who did this went actually deeper into the bladder wall than just the surface, because we have to assess how much of the cancer is on the surface versus invading into the bladder wall, and the only way we know that is to actually sample part of the bladder wall and bladder muscle itself. Again, trying not to put a hole in the bladder, because that's not what we're trying to do. Any other questions? That's a good question. Question? So the question was, a patient had 3 TUR, for the people on TURBTs, and never had pain. So there are nerve endings in the bladder. Some people are exquisitely sensitive to the surgery, some people aren't. And you know, many patients with bladder cancer are older, and sometimes the pain receptors in the bladder aren't as sensitive as people get older than when they are younger. I think that you are one of the fortunate ones that didn't have as much pain. And I don't know, again, how big your tumor was or the location, but sometimes a larger tumor with a larger area of resection can be more painful than others. Or people that have multiple tumors all over the surface of the bladder and have multiple areas of resection can tend to have more painful tumors. Sometimes the medications that we give are enough to mask whatever pain people have. But what I have found is that patients that have this surgery, it's not as painful as an abdominal incision or another type of incision that people get for surgery. I think largely because the pain receptors in the bladder are different than those in the skin or in the muscle. Question in the back. Great question. So looking at you guys are picking apart my slides and I love it. So the tumor that is on the cartoon drawing, which is not the real one, I have seen in real life. That would be considered an anterior wall or front wall bladder tumor. And in that case, we turn the scope and instrument upside down, so the loop is facing up. And then, depending on how it is, my hand will be on your abdomen, pushing down and pushing the front wall of the bladder into the field so that I can see it and scrape it. You're welcome. Okay. You guys are good. You're asking me questions I didn't anticipate. I like it. Okay. So moving on. As we mentioned, we're taking the cancer out. We're trying to get part of the bladder wall. And for the transurethral resection of the bladder tumor, the final pathology, because this will determine what we do next, right? And I want you to know how aggressive is your tumor, how invasive is the tumor. This is all for staging. And then are there any other features that are high-risk features, such as lymphovascular invasion or variant histology. Lymphovascular invasion, if the tumor is invading in the lymph system or the vascular system, that would suggest it has a way to get out of the bladder and spread to other parts of the body, which is a high-risk feature, which may flavor or change the way that we select treatment. And then variant histology. So as I mentioned earlier, urothelium or urothelial cells are the type of cells that line the bladder. Sometimes with cancer, those cells differentiate into different looking things under the microscope. And variant histology is just the way that the pathologists look at them under the microscope and say they don't look quite like urothelial cells. Some variant histology bladder cancers can be more aggressive than traditional papillary urothelium, and that may also flavor the discussion of how we decide to move forward for treatment. This is a little bit above the level I'm talking about today, but these are high-risk features. But importantly, how aggressive is the cancer? How invasive is the cancer? And so when we look at a final pathology report, we're trying to see, does the pathologist grade it as a low-grade cancer or a high-grade cancer? Now, by and large, bladder cancers will come back. 50 to 70% of patients within the first 2 years will have a recurrence, regardless of what stage the cancer is. And low-grade disease versus high-grade disease informs us on what to expect when the cancer comes back. So if it's low-grade disease, patients that have low-grade disease tend to have recurrences that are low-grade disease, and they tend to stay at the same level of invasiveness when they come back. Okay, there's no progression. It stays the same stage even though it comes back. High-grade disease, so again, low-grade disease, look for the stats, 15 to 70% recurrence in 1 year. On recurrence, same stage of invasiveness, less than 5% progressed to muscle-invasive disease. And this is the thing that we worry about. Low-grade disease is typically not a muscle-invasive disease. Muscle-invasive disease is the one that we worry about most because that's the most aggressive disease. It has effect on lifespan, and that's what involves the bigger surgery, which we'll talk about in a few slides. But low-grade disease tends to stay low-grade, tends not to become more invasive. High-grade disease, on the other hand, higher chance when they recur staying high-grade and higher chance of progressing. So if it's in the surface of the bladder, it could be deeper than that and potentially in the muscle or beyond when it comes back. And depending on what literature you read, 6 to 25% of patients will have progression to muscle invasion on recurrence. So high grade versus low grade, that's an important thing to understand when we read the pathology reports. The other thing that's important is level of invasiveness. So there's another cartoon picture that I like to show of all the different stages of bladder cancer and how they invade the bladder wall. So if we look here, this is another cartoon depiction of the bladder. This wavy pink line here with the hexagon shaped cells with the circles in the middle. This is the normal bladder surface of the urothelium. Underneath this wavy line, this purplish wavy line, this is the middle layer of the bladder, or what's called the lamina propria. It is a supportive layer of connective tissue under the surface of the bladder, okay? And this thicker red line with the big red circles, this is the actual muscle wall of the bladder, the muscle that squeezes urine out. So think of the bladder as having 3 layers: the urothelial surface, the middle layer, lamina propria, and the actual muscle wall. And then this orange, amber colored line out here, this is fat that's outside of the bladder. It's not actually part of the bladder, but it's outside of the bladder. So you have the urothelium, the lamina propria, the muscle wall of the bladder. This is the actual bladder, and then fat outside the bladder. Down here are the different stages or levels of invasion of cancer. CIS stands for carcinoma in situ. This is a flat tumor. It's usually red. It's only on the surface of the bladder. It does not go any deeper. This is always a high-grade cancer, okay? TA, or stage TA bladder cancer, again, this has the papillary shape only on the surface of the bladder. This can be low-grade, this can be high-grade, but it's only on the surface of the bladder, no deeper. T1 tumors, stage T1 is a tumor that's grown through the surface of the bladder and into the middle layer of the lamina propria, but no deeper, has not reached the muscle. T2 tumors, this is the true muscle invasive cancer. So it's through the surface of the bladder, through the middle layer, and invading in the muscle wall of the bladder. T3 tumors have grown through the surface, the middle layer, the muscle wall of the bladder, and invading the fat outside of the bladder. And T4 tumors have grown through all the layers of the bladder into the fat and invading other organs. In men, that would be the prostate, seminal vesicles, pelvic sidewall. In females, that would be the uterus, the vagina, fallopian tubes, pelvic sidewall. Okay, so here you get the T1 to the left. These are the non-muscle invasive bladder cancers. T2 and over to the right, these are the muscle invasive bladder cancers. And there's a distinction between these cancers and how they're treated. Again, this is another cartoon picture. If you're one of my patients, I'm sure you've seen this in the office. Another depiction, again, of the bladder, the different layers of the bladder, the different types of cancers, different staging, surface of the bladder, lamina propria, muscle wall, the fat, carcinoma in situ, stage TA, stage T1, non-muscle invasive, stage 2, 3, or 4, muscle invasive. And you can basically draw a line like this through the staging. And if you're on the right half, we do everything that we can to put medications in the bladder to try to treat the bladder cancers, prevent recurrences, and preserve your bladders. On the other hand, if you fall on this half of the curve, unfortunately, this is aggressive disease, which we meet with equally aggressive treatment, which is usually chemotherapy followed by complete surgical removal of the bladder. Okay. Any questions so far?
Our neighbor was a heavy smoker, wound up having his bladder removed probably 4 or 5 years ago now. They created one from either his intestine or his stomach, and he's been very good in 4 or 5 years.
We'll talk about that eventually too. But yeah, he must have had some muscle invasive, he must have had muscle invasive cancer on this side and needed the bladder removed. Conventional. I'm glad that you mentioned that, and I will clarify that as we get to that part at the end. Right. Great question. So if you're on this half, right, carcinoma in situ is a high-grade cancer. That is one that if it comes back, it could become more invasive, either into the lamina propria or the muscle. TA tumors can be low grade or high grade. If they're low grade, they probably will never become more progressive or more invasive. And people with TA recurrences that are low grade, it's a nuisance, but we can treat them and they will most likely never die of that disease. It will most likely never lose their bladders. But that's because they have low grade disease. If it's high-grade disease, or if it's T1 degrees, it's high-grade, it all depends on how well you people respond to treatment. You know, there are some people who are complete responders to, and we'll talk about the treatment regimens in a little bit, but there are some people that are complete responders to the treatments we put in the bladder, and they will never see a progression or ostensibly cured. That's about 50% of patients. The other 50% of patients will have recurrence that is more progressive, and that is usually happening within the first 2 to 5 years of treatment. So, I mean, and to that point, as we talk about the different treatments we put in the bladder and the different timing, patients with bladder cancer, as you all are aware, once they're diagnosed, if they have non-muscle invasive disease, they come back for cystoscopy, not just the one time for diagnosis, but multiple times a year, every 3 months. Then if it goes on for a couple of years with no recurrences, every 6 months, and then yearly if we can get that far. But people are coming back for cystoscopies routinely. Jillian, are there any questions online? No, okay. Okay, so this is the risk stratification scheme for patients with bladder cancer, which helps us determine if you have non-muscle invasive bladder cancer, or NMIBC, what regimens or what treatments we're putting inside your bladder. So the simplest one is the low grade or low risk category, which is a single low grade TA tumor that's less than 3 centimeters in size, or this variety of bladder cancer called PUN lump, which stands for papillary urothelial neoplasm of low malignant potential. So it's even less aggressive than TA low grade. So patients with TA low grade disease, and as you mentioned, this patient may never, as you asked, may never progress and if they recur. One-time tumor, we will often just observe these with cystoscopy. First at 3 months, then at 9 months, and then yearly. Patients that have recurrent TA low-grade disease or larger than 3 centimeter tumors or more than one TA high-grade tumor or low-grade tumor or a high-grade TA tumor or a low-grade T1. These are intermediate risk disease patients. We will typically give patients like this chemotherapy into the bladder, not the conventional IV stuff, but chemotherapy into the bladder. I'll talk about that in a second. And then patients with high-risk disease, these are patients with high-grade cancer, any high-grade cancer, high-grade TA greater than 3 centimeters, any carcinoma in situ, any T1 cancer, any variant histology, any lymphovascular invasion, things I talked about, high-risk features. People with non-muscle invasive cancer with this, the medication we give here, sorry, I'm not very good at this. The patients here, we don't typically give chemotherapy. In this case, we give the immunotherapy, which is BCG, which we'll talk about shortly. So again, treatment of non-muscle invasive bladder cancer, intermediate risk disease. Those are patients with low-grade cancers that are larger than 3 centimeters or multifocal or recurrent. Chemotherapy goes in the bladder. The two major chemotherapies we've been using are mitomycin C and more recently gemcitabine. I want to give a shout out to my colleague and mentor, Dr. Ed Messing, who is not here in this room, but one of the people that Dr. Joseph was alluding to during his introduction of me. So mitomycin C was a stalwart drug for intermediate risk disease or bladder cancer, but this has very, very bad adverse events and toxicity. And what Dr. Messing showed about 7 to 8 years ago now, I think, when he finalized the trial, was that gemcitabine was not inferior to mitomycin C in preventing low-grade intermediate risk bladder cancer from coming back, and its toxicity profile was much better tolerated. And so gemcitabine is something that is used more routinely now than mitomycin C, and that was developed here. The idea for that was developed here at University of Rochester. The way that we do this, or we give it, and you'll see this line a lot, induction plus maintenance. So induction is the first round of treatment, and for anything we put in the bladder, it's usually a 6-week course, once a week for 6 weeks. For intermediate risk disease, they get chemotherapy. After you get induction, there's maintenance therapy once a month, and I usually do this for 12 months total. And again, all the time that we're going through this induction and maintenance, at 3-month intervals, we're doing cystoscopies. At 6-month intervals, after a couple of years, we're doing cystoscopies. If there's ever any recurrence, we start back at 0. Go back to the operating room, re-biopsy, remove tumors, and the clock resets at 0 based on what the pathology is. Okay. Patients with high-grade disease, we give BCG. Again, there's induction. The maintenance schedule is different, though, than chemotherapy. You see it's longer. So the maintenance is once a week for 3 weeks at months 3, 6, 12, 18, 24, 30, and 36. Okay? Now, BCG is an immunotherapy agent, one of the first immunotherapy agents ever developed and is used in bladder cancer. It stands for Bacillus calmette-guerin. These are the two people that studied it. This is an attenuated form of Mycobacterium bovis. So this is actually a live bacterium. It says a cousin, it's in the family of tuberculosis, but not tuberculosis. Bovis means cow, so this infects cows naturally. Attenuated, meaning that all of the virulent properties of this bacteria have been removed. So all of the properties of this bacteria that cause systemic illness have been removed. But all of the components of it that stimulate strong immune responses are still present. And when this is present in the bladder, we put this in the bladder, it gets internalized by bladder cells and bladder cancer cells and innate immune cells. And all those stimulatory properties stimulate a huge response from the immune system. Cytokine release, the cytokines are chemicals released by immune cells of the innate and adaptive immune system that recruit other cells or cause direct killing of target cells. Okay, so BCG works in this fashion. Now, many of you are aware that BCG is in a worldwide shortage, and we're having a very, very hard time getting this to people. Here, we've had a challenging time. And so when I say that the worldwide BCG shortage has affected management of high-risk bladder cancer, the reason is I can often start patients on induction. And then when month 3 happens, we don't have any drug to give them for their maintenance dose. Or they can get induction and then month 3 of maintenance, and then their month 6 maintenance dose, we can't give it, and it's delayed. And unfortunately, we see people that have recurrence in those times because we can't give medication on board. There's a lot of reasons why this is going on. The biggest reason is that there used to be 2 manufacturers that made BCG, and about 7 years ago, the one factory that was in Canada, that company had to shut down for a contamination. And when they got shut down, they said, we're not coming back to make any more BCG, which shifted all of the responsibility of making BCG to one company. And that one company at maximal output has not been able to meet the demand for patients with bladder cancer. Part of the challenge is that this is not a chemical that you mix compound A and B and put in a shaker and 4 hours later have drug, right? This is a live attenuated bacteria that grows and doubles on its own schedule. It has a life of its own, so to speak. And its doubling time is about 18 hours. So to get 1 turned into 2, it takes 18 hours. And in that 18 hours, any number of things can go wrong and contaminate that batch, and you lose everything you have. So quality control is a major issue or problem with BCG. And so now the company the sole company that's still making this, they are 100% on board with ramping up production by building a brand new facility. But as you know, with any major large building or facility, it takes multiple years for that to get up and running. So they say it's in process. I have no idea when that means they're going to be alive and running. So the question for those of you listening at home, is it also in shortage because it's not as much of a moneymaker because it's been around for a long time? That is a question for the pharmaceutical companies, not for me. If you want me to speculate, I could speculate with rose-colored glasses and the optimism hat that Merck is doing everything they can by building a second facility. I could also put on a different hat and say Merck also makes other drugs that are in this space that they're trying to use for BCG alternatives, and are they promoting that? I don't know the answer. But it is a great question, and I think something that we can circle back to in a couple slides, because what I'll share with you next is that there are new therapies on the horizon for non-muscle invasive bladder cancer, and the current use for this and their FDA approval is in the BCG, the carcinoma in situ BCG unresponsive state, right? So patients that have carcinoma in situ that have failed BCG or can't get it, these drugs are approved for. Now that is for high-risk disease, and only one category of high-risk disease, carcinoma in situ. There's still TA high-risk, high-grade, and T1 high-grade disease. And there's people that have never seen BCG that have high-risk disease. So right now, as we speak, these four categories, and I'm gonna go through them in a little bit. These 4 categories are new drug agents that are being that are approved for patients that have seen BCG with carcinoma in situ and failed. What's happening, I see, let me finish my point. What's happening is I expect fully that within the next few years, these drugs are going to move earlier in the treatment paradigm. And we're going to see clinical trials using these drugs in BCG naive, carcinoma in situ, or high-grade disease to see if they can supplant BCG as first-line treatment. They may or they may not, but I think that's forthcoming. It's just going to take a few years for us to get there.
So this BCG and the light and the topical chemo, is that only for high grade or the more passive treatment of low grade? Is that how it's kind of split?
So,
So if you have low grade, would you get BCG or?
right. So if you have low-grade intermediate risk disease, go back. Right. So the stratification, low risk disease, intermediate risk disease, high risk disease. Low risk disease, low grade. Most of these people honestly never recur, or if they do recur, it's low grade, which would bump them to intermediate risk disease. So you can see intermediate risk disease is patients with low grade tumors or a small high grade tumor, but mostly low grade. So these are patients that I would treat with chemotherapy in the bladder. Patients with high risk disease or high grade cancers, those are the people that I give BCG first. Now, people with intermediate risk disease here, this is a great question you asked. If they get chemotherapy in the bladder and then they fail and have recurrences, I'll bump them over into the high risk group and give them BCG. But typically in my practice, and what is in the guidelines for people that treat patients with bladder cancer, is the real is that BCG is reserved, especially in the era of BCG shortage. BCG is really reserved for patients with high-grade, high-risk disease. So if you have intermediate risk, low-grade disease, chemotherapy. If you have high-grade, high-risk disease, BCG, non-muscle invasive. Does that answer your question? Okay. It's similar. So the question for those at home is how do we administer the medication, the chemotherapy? And the same question holds true for the BCG because we give it the same way. So it's an intravesical, meaning inside the bladder installation. So people will come to the office. We'll place a Foley catheter through the urethra into the bladder. We'll empty all the urine out of the bladder. And then with that tube in place in the bladder, we will fill the bladder with the medication. Okay, and then it sits in the bladder. Some people, depending on the patients and how they're doing, if they're able to hold the medication on their own, we'll take the catheter out, and then the patients will hold the medication in their bladder and often leave the office and go home and urinate the medication out at home after a couple of hours. Sometimes these medications, and I didn't list it here, but the biggest side effects or complaints that people have is that it can tend to irritate the bladder and make people feel like they have urgency and frequency and can't hold their urine. And so for patients like that, we will bring them in, put a catheter in, drain the urine from the bladder, put the medication in the bladder through the catheter, and then put a plug on the catheter and keep the catheter in place for a couple hours, and then drain it and let people drain that way.
Thank you.
Okay. Other questions? Okay. Now, as I was mentioning, we have new therapies, and this is hot. This is the stuff I was saying is hot off the presses, because this is what was just presented at our AUA meeting about 3 weeks ago. And all this is new. All these drugs have been FDA approved and are just now starting to become available. And we are starting to talk with some of the pharmaceutical companies on how to make them available here in our office so we can provide them. But there are 2 gene therapy drugs, Adstiladrin, or for those of you who can really read, Natafarigine, Feridenovec. CG00700, and this one kills me because I can't pronounce this one. It's Cretostimogene, and I think it's Granadinorepvec. I don't know who makes these names, but Adstiladrin and CG0070 are definitely easier to say. These are gene therapy agents. There's two of them. There's a BCG superagonist, which is the NAI, NA03, and then there's also a sustained intravesical drug delivery system, which is TAR-200. So all four of these are new drugs in the BCG unresponsive carcinoma in situ space that are now available. They all got FDA approved. And I think over the next few years, we're going to start to see them being used earlier. Whether they supplant BCG or not, I don't know. Just because I'm thinking about it, and you mentioned it about the potential economics of this, I'm going to go through slides and show you the exact slides that were presented at our meetings. The authors, the presenters of these studies were kind enough to provide me with their slides, and I'll show you their actual slides from the meeting. And you'll see that the results are really, really good. And the question is going to become, which one do we choose? Because now there's four. Up to now, we had nothing, right? And we've been using BCG for 30 to 40 plus years. And up till now, we've had nothing. So brand new, 4 new drugs. And the first question I have is, which one are we going to use? One is going to be, which one can we get in our office? But largely, and I don't know the answer to this, because the question was posed at our meeting, how much does this cost for each one of these? And none of the people giving the talk, they're all urologists. They're not the people that sign the price tags. Nobody knows. And part of it is, how much is it going to be covered by insurance or Medicare? I don't know the answer to that. But I think just based on consumerism, most people will probably use economics and price to choose which one of these 4 they go to next. That's my own personal opinion. I don't know the answer, how it's going to shake out, but that's my thought. But let's talk about the new treatments. So the first one, this was actually FDA approved in December 2022. Fast forward a year and a half, almost 2 years, we're just hearing about it now because this natafarigine furdenavec, or Adstiladrin, this is a gene therapy for BCG unresponsive CAS. Basically, the gene therapy is a vector. It's an adenovirus that has this linker, SYN3, which helps it get into the bladder cells and bladder cancer cells. The adenovirus then releases the transgene. So gene therapy, if you're not familiar, is a process of taking a gene that is not expressed in a cell and putting it inside that cell so that cell can express that gene and make whatever the payload is from that delivery. And so in this case, we have an adenoviral vector that is infecting the bladder cancer cell, and what it's carrying is the DNA sequence for interferon alpha. This bladder cancer cell that's taken up this adenovirus now starts to make interferon alpha, which is a cytokine or protein that is stimulatory to the immune system. This cell secretes the interferon alpha out, and it recruits all these different immune cells to the area, which then have an immune effect on the cell. The interferon alpha also promotes upregulation of death receptors on the cancer cell, which then causes and induces the cell death of the cancer. So this is the mechanism of action for this. And you can see on the results of the trial, 50% of patients with high-grade CAS had a complete response after the first dose, and this drug is administered once every 3 months. And again, in the bladder, just like all the other medications we're talking about, but rather than being a chemotherapy agent or BCG, it's a gene therapy agent which gets into cancer cells, has a payload gene that gets transcribed. This is interferon alpha, which has all these effects on actual tumor cell death and recruiting the immune system to the system. 50% of patients had a complete response in 3 months, and of those patients, 50% of them had durable response 1 year later. Okay. The next one is another gene therapy. This is the one with the name that I can't pronounce, cretostimogene grenadenorepvec. Actually, I think that's a pretty good job. CG for short. Again, this is another gene therapy agent. Again, it's an adenovirus here that gets taken up by cancer cells. The actual adenovirus in this case is different than the one that was used for Adstiladrin. This one, direct uptake is directly cytotoxic, meaning it kills the cancer cells that take it up. But it also has a payload gene, which is GM-CSF, which is another potent stimulator of the immune system and development of immune cells that recruits immune cells to the bladder to fight off the cancer and recurrences. Okay. This one, very impressive. Anytime, the complete response, 75%. At 3 months, 68%. At 6 months, 63.6%. This doesn't have year-long data like the Adstiladrin does because it hasn't been a long enough trial. But in January, the FDA gave this breakthrough therapy designation to be used for patients with carcinoma in situ that's refractory to BCG. The phase 3 trial is ongoing, but because the results were so good, that's how they got FDA approval moving forward. Okay. Correct. At this current time, the only indication is if you have CIS and are refractory to BCG. And the reason that is because it's very challenging to do clinical trials to show efficacy in the bladder cancer space, because carcinoma in situ, as I mentioned earlier, is always a flat, high-grade tumor. But what I didn't mention is that it can be anywhere on the bladder surface, and it's hard to remove all CIS. Compared to a single solitary papillary tumor that we remove, you could argue that us doing the surgery was curative because we removed the tumor. And so if you have a patient that has a papillary tumor and a urologist removes it, and then we put a medication in the bladder, and 6 months later we look in, what was the event? Was it the removal with surgery, or was it the drug? Versus CIS, we know going in that it can be anywhere, and when we remove the part that we see, there's probably other CIS that we're not seeing or removing completely, or haven't removed. And so in that case, when you put in a drug, if there's no CIS at the later time point, then you know it was a drug specifically that removed that. So that's the challenging part of getting drugs for bladder cancer and non-muscle invasive bladder cancer approved by the FDA. Because in order to show actual efficacy of the drug, we need to show there's some residual disease left behind that was eradicated by the drug. And you can't do that with solitary tumor. And so that is the pathway for these pharmaceutical companies to get their drugs approved. And now that they're approved, this is why I'm saying I think we're going to start to see them used in earlier stages with papillary tumors without CIS, because now they have an indication for use. You know, and in fact, Adstiladrin's doing that already with an arm that they haven't published yet, but they're enrolling to that. And these trials are definitely, they have other cohorts or arms that they're going to report on now that these are public. Okay, but that as of right now, you are understanding me correctly, it's only for CIS. Okay.
Can you compare, I know these are brand new, just a couple of years. My understanding was BCG had about 65% success rate over 10 years. And I know can you compare what the prognosis is for these things compared to BCG? And then, you just kind of wonder with the success of BCG where the FDA has been.
That's a
The last 15 years, my understanding.
That is a great question. So you're quoting 65% success rate for BCG, anywhere between 50 to 80%, depending on what literature you cite and what study you're absolutely right. So these trials were not head-to-head comparisons with BCG, because these were trials in patients that had failed BCG. Okay, and we only have, for Adstiladrin, I think 3-year data, for CG a year plus, so we don't have the long term. And the quickest way to approval through the FDA's eyes is, in this case, doing a CIS study in BCG unresponsive patients, because they have nothing else for offer. So if you're getting any response, that's a win, and you're going to get approval by the FDA. Now, as far as comparing these drugs head-to-head with BCG, it's kind of an unfair comparison at this point because this is in the BCG unresponsive space, right? So these patients have already failed BCG. I think we're going to learn the answer to your question in the years to come once these drugs start getting used in the BCG naive population. I think it will be. There's going to be so much demand when we don't have BCG to start using these earlier, and their trials there's different arms of each of these trials that have a BCG naive population, and we're going to start to see the answers to those questions. Now, whether they're going to actually be similar to BCG 10 or 15 years out, it's just going to take time for us to learn. The other thing that I want to mention, because you brought it up, is, you know, if I say here, Adstiladrin had a 55 or 53.4% complete response rate in month 3 versus the CG drug had 75% anytime in month 3, 70%. This is clearly better, higher, why don't we use this? You can't actually compare the numbers head to head like that because the two trials were run differently and independently of one another. So the patient populations are a little bit different, so the numbers are going to be a little bit different. You can't just take one trial and compare it to another side by side if the two drugs weren't being compared side by side in the trial. It's very easy, very nice to look, oh, the numbers are higher and then we should use that, but that's not really appropriate way of looking at the trials and comparing them head to head if they were not put head to head against each other in the same trial. Okay. Any other questions about the gene therapy? Great question. So the majority of the bladder cancers start from the urothelium, which is the lining of the bladder. There are some cases, though, where I have seen, and it's rare, but it can happen, where the cancer it still starts in the urothelium, but rather than growing into the bladder, it burrows into the muscle already, and so you get a lump, or excuse me, a bump seen on imaging or cystoscopy with a smooth-looking bladder surface, but a lump underneath. And that is still a bladder cancer. It started from a cell within the bladder, but doesn't have the classic papillary tumor appearance. And I've seen that rarely, but it does happen. And it often happens more in my experience in patients that have those histologic variants rather than true urothelial cancer. But the majority of them do start from the surface of the bladder, but they all start within the bladder. Anything that comes from outside the bladder, I have not seen a cancer arise from the fat outside of the bladder pushing in. And if that were the case, then we wouldn't characterize that as a bladder cancer. It would be whatever source of that cancer was, fat, lipoma, or somewhere else. In men, prostate cancer can invade into the bladder. So then it would be a prostate cancer invading into the bladder, or a fat lipoma invading into the bladder, not a true bladder cancer. It would be treated what the primary was, either prostate or lipoma or whatever. Okay. Okay. So the other two drugs that were revealed or shown at our AUA meeting is this NAI, NA803, IL-15 superagonist. The picture of it is here. This is actually designed to be used in conjunction with BCG. That's why it's an agonist or superagonist. So what this does, this is basically an antibody structure with the IL-15 receptor. IL-15 is a very potent cytokine stimulator of the immune system. So this holds IL-15 in this IL-15 receptor, and in conjunction with BCG in the bladder, it recruits immune cells very strongly to the site, natural killer cells, which then stimulate adaptive immune responses with B cells and T cells. And that, in this setting with this trial, is shown to have a better response in patients with BCG unresponsive disease. And again, at any time, 70% complete response rate. A year later, 62%. 90% of patients here did not end up having their bladders removed. Okay, so again, another agent that is really good, really promising. And this one, just last month, April 2024, was approved for BCG unresponsive patients with carcinoma in situ. And then the last one that I'll share with you that was presented at our meeting is this improved or sustained intravesical drug delivery system called TAR-200. And again, this also has FDA breakthrough designation. So as I mentioned, the gentleman in the back asked, how do you put the chemotherapy or how do you put the BCG in the bladder? And we put a catheter in, we drain the bladder, we put the chemotherapy in the bladder, let it sit for a couple hours, and then people go and urinate it out later. So that's a 2-hour dwell time of chemotherapy. And the question is, how long is adequate, right? And this trial was looking at sustained release of gemcitabine. And what you see here is a cartoon picture of the bladder and this pretzel device. So this pretzel device actually comes as a strip. And we use a cystoscope to put it in the bladder. And then we deploy it. And it has a coil in it. Once we deploy it, it makes it coil like this pretzel. That way it stays inside the bladder. You can't urinate it out easily. But this pretzel or this coil has gemcitabine in it. And it's slow release gemcitabine. And I believe the duration of slow release gemcitabine is 6 weeks. So it's not a 2-hour dwell time of gemcitabine. And if you recall, when we talked about how gemcitabine is delivered with induction, it's once a week for 6 weeks. So that's 12 hours over 6 weeks of gemcitabine when we do it in the office, versus this sustained delivery of gemcitabine in the bladder for the entire 6-week time period, no pauses or breaks. And with this, again, for patients with carcinoma in situ that had failed BCG, and if you recall, I told you beginning, I reserve chemotherapy for low risk, low grade, or intermediate risk, low grade patients, and reserve BCG for high risk, high grade patients. This is a very high risk patient population that's failed BCG, and it's single agent chemotherapy, which I just told you I'm reserving for the lower grade patients. Complete response rate, 76%. This is from all people involved. An investigator assessed this as people at individual sites of the trial, 80%, but 76%, 80% have complete response rate. I can't remember the time frame of this, but definitely really, really good responses, which led to the FDA approval. So again, these are 4 new drugs available in the non-muscle invasive bladder cancer space that were not available before, all within the past year. And right now, reserved patients with BCG refractory CAS, but I think we'll be seeing them sooner. Okay. So this is partly what I was mentioning earlier. How do we choose the 4? I think part of it is how easy is the drug to get from the manufacturer. And again, chemotherapy pretzel versus super agonist. The super agonist requires BCG, so if we have BCG shortage, we're gonna have a hard time getting that. This pretzel is pretty stable. The gene therapy agents may require us to have different refrigerators in our freezers in our pharmacy to be able to handle that. I don't think it's gonna be an issue. But I think part of it is gonna be what we as our office can negotiate with those pharmaceutical companies to get it. And again, ultimately, I think it's gonna come down to you as patients or consumers in this sense, and how much is this gonna cost? Because I don't know the answer to how much these cost, but the answer, my gut tells me is that per installation, more than $10,000 per installation, at a minimum. right? And so with the newest, fanciest medications, you also have the highest price drugs. And I mean, the 10,000 plus is what I heard rumors of at the annual meeting. So again, I don't know how we're gonna choose. I mean, all the results seem to be pretty good and pretty comparable across the board. I think it's gonna come down to what are the side effect profiles? What are you willing to tolerate? What are we able to provide, and what are you ultimately able to afford? Unfortunately, or fortunately, because now there's 4 choices, right? It's just gonna be like, can you afford the Mercedes, the Jaguar, or the Toyota? I don't wanna simplify it that way, but I've been thinking about this a lot. I think that's a big part of the discussion, and no one is really talking about or discussing it at that level. But that's kind of how I think it's going to play out. Personal opinion, totally speculation. So the question is Merck. So the natafaragine is produced by a company called Ferring Pharmaceuticals. The cretostimogene is the CG drug is made by a company called CG Oncology. The IL-15 superagonist, I can't remember who makes that. I'm not sure anymore. And then the gemcitabine pretzel, the TAR-200 is made by Johnson & Johnson. So all different drug companies. Overall, I think the toxicities are very similar. I have those slides with me. They're all very similar. Urgency, frequency, visible blood in the urine. Those are all things that we see with patients that get medications put in the bladder. Okay. How's everybody doing? We're good? Okay. So now we're going to switch gears to muscle invasive bladder cancer, which is the really aggressive cancer. And this, and I don't know for those of you who have seen other urologists, but I will put this on the table at the beginning when I start counseling patients. Regardless if you have non-muscle invasive bladder cancer or muscle invasive bladder cancer, because I like people to understand the full spectrum of disease and where they are in the spectrum as far as low grade versus high grade or non-muscle invasive versus invasive. Because if it's high grade disease or it's T1 high grade with CIS, there's a high chance of progression at some point to be muscle invasive, or there's a possibility that you'll get BCG and fail. And prior to today, we didn't have those 4 other drugs, and we were talking about the bladder being removed because we had no other alternatives, right? So I think it's always important to know that at the final stop, potentially we could be talking about removing the bladder. So muscle invasive bladder cancer is T2, T3, or T4 disease. The gold standard treatment for patients with muscle invasive bladder cancer is neoadjuvant chemotherapy, followed by a radical cystectomy, a pelvic lymph node dissection, and creation of a urinary diversion. Now, neoadjuvant chemotherapy, neoadjuvant because it is chemotherapy that we give before surgery. And this chemotherapy, as we alluded to earlier, in this setting with muscle invasive disease, it is not chemotherapy into the bladder, but conventional chemotherapy given systemically through an IV. Okay. The alternate therapy, again, this is the gold standard, and nobody ever wants to hear that their bladder has to be removed. I do it often. I tell people this often, but nobody ever wants to hear that. And if there are things that we can do and try to mitigate that, we can. The alternate therapy is trimodal therapy. This is a bladder preservation strategy, so bladders aren't removed here. But it's not the first line treatment or gold standard. But this involves a maximal transurethral resection, meaning we go in and cut as deep into the muscle wall as you can to try to get all the cancer out as possible. And then patients get chemotherapy and radiation. I'll talk about this a little bit later as to why it's not preferred. This is recommended for people who absolutely refuse to have their bladders removed or who are not well enough to undergo general anesthesia and the big procedure that removing the bladder is. Okay. Now, neoadjuvant chemotherapy, as I mentioned, it's the administration of chemotherapy prior to surgery, prior to radical cystectomy. Why do we give it? So these numbers don't look very impressive. A 5 to 7% absolute improvement in overall survival for patients who have their bladders removed. 5 to 7%, and you're saying, why are you doing that, giving me chemotherapy, which has hair is going to fall out, my immune system's going to be weak, I'm going to be weak. Why, for some people, a 5 to 7% absolute improvement doesn't seem like a whole lot. And I'll share with you this graph. So this is the graph from the clinical trial that was done at MD Anderson for patients that got chemotherapy prior to having their bladder removed. And ultimately, that 5 to 7% overall improvement in survival, it doesn't seem like a lot, but when you look at the curves and see how they separate, the top curve is people that got chemotherapy first, and then their bladders removed. The bottom curve is the people that only got that just got their bladders removed. There's a significant spread in how long these people are staying alive after their surgeries. The biggest thing, the median survival, 77 months for people who got chemotherapy first, compared to only 46 for people who didn't get chemotherapy. So that 5 to 7% survival advantage is actually 2.5+ years difference. So even though it doesn't seem like a lot, the actual amount of time that you get, 2.5+ years, which is why we recommend this before getting the bladders removed. And so what do we do when we take the bladders out? This can be done either robotically now or the old-fashioned way, which I like to do, which is through an open incision. But in men, the bladder, prostate, sentinel vesicles, and the lymph nodes come out, pelvic lymph nodes. In females, it's the bladder, fallopian tubes, ovaries, uterus, plus or minus the vagina, depending on how much of the cancer is involved with the bladder. So the back wall of the bladder sits on the front wall of the vagina. So if there is involvement of the back wall of the bladder, or worry that the vagina is involved, the vagina will be removed also at the time of surgery. But if it's a front wall or side wall tumor that does not appear to be involved with the vagina, we will try to spare the vagina in women in this surgery. And then pelvic lymph nodes are also removed. We talked a little bit, you had a friend that had a piece of bowel put into a pouch and everything's on the inside. That's called a continent diversion, continent urinary diversion versus an incontinent urinary diversion. So when the bladder comes out, people always ask, well, what happens to my urine? And we have to find a way to divert it. The simplest way to do it is through the ileal conduit, which is an incontinent diversion. I have a picture of this on the next slide. But basically, we take a piece of small bowel, about 20 centimeters long. We sew the ureters, which are the tubes that bring urine from the kidneys to the bladder. Bladder's removed. We put the ureters in one end of the conduit, and the other end goes to the abdominal wall and exits the abdominal wall as a rosebud stoma, and urine drains into an external appliance bag all the time, hence an incontinent reservoir. Versus the continent reservoir, which is what the gentleman here in the front, his friend had. A larger segment of bowel is used. Now the bowel is a long tube. We will cut one side of it open and then re-sew it back to be like the shape of a sphere, or try to do our best. Ureters get sewn into one end, and then that sphere gets hooked back up to the native urethra on the inside, and the urinary diversion is on the inside of the patient rather than on the outside. And it is a continent diversion because urine doesn't drain all the time into a bag, and most people after the surgery still have control of their voluntary urinary sphincter, and then it can attempt to void through a neobladder or a new bladder made out of bowel. And everyone always asks me, well, doc, that sounds so much better than having a bag on the outside. Why don't you do this for everyone? And the bottom line is, as much as we try to recapitulate bladder function with bowel, bowel is not bladder. And even though we've taken that bowel and reshaped it into a quasi-sphere sac that can store urine and put it to the urethra. It does not have the muscular structure to squeeze like a bladder does, to be able to empty completely as well as a bladder does. It does have some ability to squeeze, but there is a high chance for urinary retention. Bowel also makes mucus because it's supposed to lubricate the lumen to allow for stool to pass. Just because we have repurposed it to be bladder, it still behaves like bowel and will still make mucus. And mucus can also plug the urethral opening and prevent people from being able to empty completely. And so people that have urinary stasis, mucus plugs, are at high risk of forming bladder stones and bladder infections in their neobladders. And to prevent that, people have to be able to willing to catheterize themselves in order to empty their bladders if they're not emptying well. And for many people, that's a non-starter. The second thing is that even though there is a quasi-bladder in place, the sensation to go to the bathroom is not like you have to urinate because it's bowel in place of bladder. And in fact, what people tell me is when their neobladders get full, it feels like they almost have to have a bowel movement rather than void. And so you have to learn those sensations, those signals. And when I say truly continent, again, the urethral sphincter that they're using to stay continent is their voluntary sphincter. If you recall, when we were all babies, we had no control over our voluntary or involuntary sphincters, and we wore diapers. And as we got older, we got control over our voluntary sphincters, but also our involuntary sphincter that kept us dry in social situations. Well, the involuntary mechanism has been removed due to the surgery, and now people are only relying on their voluntary sphincter to stay dry. And the capacity of the neobladder may approach the bladder, but usually a bit less, and so people are emptying their bladders every 3 hours. And to stay dry at night, you have to get up every 3 hours to drain the neobladder in order to stay dry. So it's a continent reservoir to a degree if you maintain it. And so ultimately, a lot of patients, I mean, I have some patients that are very adamant they didn't want any bags on the outside and want to do the internal bag, and that's fine. But people have to be well motivated to maintain it and manage it. And the other thing that we talk about for the neobladder is, again, this is bowel repurposed as bladder. The bladder natively is designed to hold urine, which has excretory waste products in it. And the bladder is inert to those waste products, so they all leave the body without being reabsorbed. The bowel is designed to reabsorb nutrients, and it has no idea if it's got food or urine, right? And so if you've got a neobladder in place and you've got stagnant urine or urine that hasn't drained out, and it's a larger surface area of bowel used for the neobladder than it is for the conduit. And in the conduit, the transit time for urine through is fast because it's always draining. But there's a potential for people who have bad liver disease or bad kidney disease, if they have a neobladder, to reabsorb all the extra waste products that were made and put in the urine through the neobladder, and then they can't handle the extra waste load because their kidneys are bad or their livers are bad. So again, that's another reason not to do a neobladder. Question from somebody that works here. So the decision to decide who gets what is, ultimately, it's a patient's decision. But it's my job to explain to you what each one entails. And, you know, I don't want to paint this as a negative thing because I think the neobladder in the right patient is the right option. But a lot of times I get to the point where I say, you have to catheterize yourself, and that's it. No, I don't even listen anymore because people aren't willing to do that. You know, but if you're not willing to do that, then you have to learn, or you have to understand your risks for retention and stones and infection are going to be really high. And as a surgeon, for someone that's not willing to do that, catheterize themselves are really motivated, we have to have a really candid discussion, serious discussion about that.
Just a point, I have a high school friend who had his bladder removed 25 years ago, and he opted for the bag, and he's been very pleased.
Right, and so I think there are lots of different, so you have a friend with a bag and a friend with a neobladder. You got one of each. So I think, and is your friend with the neobladder also happy? You think so? So I think ultimately it is how we address patients and tell them what to expect with each diversion and managing or setting people up for success based on their expectations, right? If someone says, there's no way I'm gonna tolerate having a bag on the outside, you gotta put everything on the inside. If I gave them a bag on the outside, they're gonna be unhappy with me no matter what I do, because that's not what they want. And regardless of how much work they have to do to maintain and manage a neobladder, if we put it on the inside, if that's what they want and are motivated to do, they're gonna be happy with that, or as happy as they can be. You know, there are lots of different studies that I won't show or get into, asking patients with neobladders or ileal conduits what their quality of life is like. And ultimately, once they get over the hump of realizing they had bladder cancer and their bladders removed and they have a urinary diversion to manage, once it becomes part of their daily routine, most people have the same quality of life scores afterwards. You know, the ileal conduit has the other added downsides of body image altering with the rosebud stoma in the back. And this is what it looks like, right? So this is a piece of bowel that we harvest. The ureters get sewn into one side, and then this end gets brought out here. And here's the rosebud stoma. This is a wafer, adhesive wafer that holds the bag on, and then urine in the bag. You know, clearly body image altering and changing. Some people that is a big deal. Some people it's not such a big deal. You know. So there are several different appliances available now. A lot of it has to deal with the leaking, as you mentioned, has to deal with how well the rosebud protrudes from the abdomen versus is it flush or is it retracted? You know, and those that are flush or retracted don't do as well as the common appliance. And there are now convex appliances that people wear that help with the drainage. Some people have extra straps or bands that keep things on that help with the drainage. So yes, the bags have come a long way from just being a simple stick-on appliance. There are others with different shapes and promote that. And it's just, honestly, it's trial and error for a lot of people. There are different adhesive pastes that can be used in adjunct to the adhesive on the wafer that people find beneficial. And we work with the ostomy team in the colorectal surgery department, and the nurses there are fantastic. 5, 6 different appliances with different wafers and different adhesives that trial and error for people. But based on patient's anatomy, and again, the location for this, it can be, so here's our belly button, it can be here, it can be up here. We look at each patient individually to see where the belt line is, where the skin folds are, how the abdomen lays, sitting, laying, or standing, to find the best place to not interfere with clothing or anything, and go from there. Okay. Other questions? We're nearing the end. Okay, I promise. The other thing is, I talked about the multimodal therapy, the trimodal therapy, which is the maximal TRBT followed by chemoradiation. This is for patients who are unfit for surgery, or who absolutely refuse their bladders removed. We don't know if this therapy equals radical cystectomy. There's no way of knowing, because the only way to really do it is to do a head-to-head clinical trial where you enroll patients and half of them get cystectomy and half of them get radiation. And ethically, there's no trial that we can enroll where people will be able to be blinded to what therapy they get, because they're going to know. And there's going to be, I don't want this, I want that, I don't want that, I want this. And it's just impossible to enroll that trial. So the best that we can do is to look at historical patients treated with radiation versus historical patients treated with radical cystectomy. And what we know is that the patients that do very well with radiation are only a select handful. So patients that have one tumor that's less than 5 centimeters in size, that has no carcinoma in situ, no hydronephrosis, no variant histology, you know, all the things that I listed are super high risk, and those patients fail miserably on radiation. And the patients that don't have those high risk features, only about 30 to 40% of all bladder cancer patients need their bladders removed. So it's a very small select patient subset. And ultimately, of those patients, 1/3 of them have a recurrence or progression and need to have their bladders removed. So we have to be very careful with trimodal therapy and radiation, who we select for that. But I think this area, an area that I'm interested in studying, has a tremendous amount of room for growth, because ultimately people don't want to lose their bladders. And I think as a community, and I'm a surgeon, this is my favorite surgery to do, but it's not one that ultimately is helping people. I mean, I think it's helping people, but it's not what they want. They'd rather have their bladders cured with a pill or something and not lose everything with major surgery, and I can understand that. Moving forward, this now jumping up higher beyond muscle-invasive bladder cancer to metastatic bladder cancer. So the most common site of spread of bladder cancer outside the bladder is the pelvic lymph nodes. Spread in the bloodstream to the liver, lung, bone, adrenal glands, or intestine is common. And people with metastatic disease, the very poor with very, very chances, very, very limited chances of cure. Now that being said, there have been recent advancements in metastatic bladder cancer care. So for 30 plus years, all we had was chemotherapy. 6 years ago, we got immunotherapy with immune checkpoint inhibitors. And then in this past year, all that was supplanted by another drug combination of an immune checkpoint inhibitor plus this drug called enfortumab vedotin. So 2 drugs in the combination therapy. Enfortumab vedotin, again, one of these really odd names, but the drug is here. So it's an antibody. This part of the antibody binds to a marker on bladder cancer cells. And these red dots are depicted here. They're linked to the antibody. And this is monomethyl auristatin, or MMAE, which is a drug that binds to microtubules in cells and prevents them from dividing. So it ultimately kills. Cancer cells are fast growing. They like to divide and grow. This drug binds to the microtubules and doesn't allow them to split, and so the cancer cell dies. But what ends up happening is this drug, by this antibody, gets taken up by the bladder cancer cells, taken inside the cell. The drug gets released, and it prevents the cell from replicating. Now over here is pembrolizumab, which is one of the immune checkpoint inhibitors. So what was learned